Before watching this video, click on the subscribe button. Clinical morphology or mechanism of action of potassium citrate extended release tablet. This is my second part of the video. If you want to watch the complete review regarding potassium citrate extended release tablet, so check out the link that is given into the description box. So let's start how these potassium citrate extended release tablet works. So first of all, when given orally, the metabolism of absorbed citrate produces an alkaline load. The induced alkaline load in turn increases urinary pH and raises urinary citrate by augmenting citrate clearance without majorly altering ultrafiltrable serum citrate. In addition to raising urinary pH and citrate, increases urinary potassium by approximately the amount contained in the medication. It causes a transient reduction in urinary calcium. The changes induced by K-STON produce urine that is less conductive to the crystallization of stone-forming salts like calcium oxalate, calcium phosphate, and uric acid. Increased citrate in the urine by complexing with calcium decreases the calcium ion activity and thus the saturation of calcium oxalate. The citrate also inhibits the spontaneous nucleation of calcium oxalate and calcium phosphate, that is also known as brushite. The increase in urinary pH also decreases calcium ion activity by increasing the calcium complexation to dissociated ions. The rise in urinary pH also increases the ionization of uric acid to the more soluble urate ion. Therapy does not alter the urinary saturation of calcium phosphate since the effect of increased citrate complexation of calcium is opposed by the rise in pH-dependent dissociation of phosphate. The calcium stones are more stable in alkaline urine. In the setting of normal renal function, the rise in urinary citrate following as a single dose begins by the first hour and lasts for 12 hours. When multiple doses, the rise in citrate excretion reaches its peak by the third day and averts the normally wide circadian fluctuation in urinary citrate, thus maintaining urinary citrate at a higher, more constant level throughout the day. When the treatment is withdrawn, urinary citrate begins to decline toward the pre-treatment level on the first day. The rise in citrate excretion is directly dependent on the dosage. In patients with severe renal tubular acidosis or chronic diarrheal syndrome where urinary citrate may be very low, less than 100 mg per day, it may be relatively ineffective in raising urinary citrate. A higher dose may therefore be required to produce a satisfactory citrate-uric response. In patients with severe renal tubular acidosis in whom urinary pH may be high, it produces a relatively small rise in urinary pH. Let's talk about the structure of potassium citrate. So here is the structure in this picture. K-STON is the citrate salt of potassium and its empirical formula is given as C6H5O7K3H2O and it has the following chemical structure as you can see in that picture.